Thank you very much. First of all, thank you very much, Dr. Shine, for inviting me. Thank you, SIRM, and thank you, Health Asia. In front of the August gathering, all colleagues, Assalamu alaikum. In the beginning, I was given 40 minutes, then it was reduced to 30 minutes. Then the latest I got कि 20-25 मिनट में ख़त्म कर दें, तो मैं कुछ स्लाइड्स को स्किप करूँगा, but I'll try to maintain कि जो मैसेज है वो कन्वे हो जाए. So Bismillah Rahman Rahim, in the name of Allah, the Gracious, the Most Merciful. Role of ultrasound in recurrent miscarriage. That's a topic which I've been given. We have to see in the beginning the sac, the fetal pole, yolk sac, fluid, uterine wall, adnexa, and the most important which I'm going to discuss will be the cervix, which is the topic today. Everyone is aware of this picture, urinary bladder, the way the uterus looks like, anteverted, anteflex. And this is the long axis and transverse, so I'm going to skip those basic slides fast so that I can contain with the... When we talk of gynae, it is important to do the endovaginal. When it is early pregnancy, it is also important to do with endovaginal. We can misdiagnose if we don't use abdominally. And coming to the first slide that shows this structure, we see a follicle-like structure in the left adnexa, but we see the endometrial canal is thick and prominent. As you can see, if I can show with this pointer green, that the canal is thick and prominent. I'm not sure that whether she's pregnant or she just aborted, but I do see the canal is thick. In such situation, we are going to report it as corpus luteum in the adnexa and repeat ultrasound or do the endovaginal. The characteristic of a good sac means that there is an echogenic rim around it. There is an echogenic rim around it, as you can see right here. It should be thick, white, and regular. Means it is normal. Anything missing in this, we are dealing with a problem. When we see a well-defined sac, which corresponds to 7 weeks, 2 days, or beyond, and we don't see the fetal pole, is it an embryonic pregnancy or it is a blighted ovum? In this situation, when the gynecologist do PV examination, she says that I can still see that the sac is enlarging, and I am reporting that this is a blighted ovum. When we come to yolk sac, which is the earliest structure, identification is very important and the size is very important. Anything which is beyond 0.6 centimeter yolk sac may result into miscarriage, and this is a patient where we would like to scan till we see the fetal pole and cardiac flicker. So yolk sac is a very good indicator of a normal or an abnormal one. In this sac, you can see there is a yolk sac right here, and it measures 8.1 mm. Everything going smooth, but I'm worried that this may not result into a normal pregnancy because the yolk sac is bigger than 0.6. This is 8.1 mm. In my practice of 41 years, I've come across only 3 patients. I see almost 26,000 patients a year. I've come across only 3 patients where the yolk sac was bigger and yet the pregnancy continued. In rest of them, they all failed. It resulted into miscarriage. So see how important the yolk sac is. The other structure which results into repeated miscarriage is the corpus luteum formation. So if the patient is pregnant and we don't see the fetal pole, we don't see the sac, but we do see some structure in the adnexa that could be corpus luteum, number one. If we see the fetal pole and we don't see the corpus luteum, it may result into miscarriage. So this is a very important adnexal cyst, which we call them as a corpus luteum, and it may vary in size from 3 into 3 centimeters up to 5 into 5 centimeter, or may even enlarge. If we see the fetal pole and we see the enlarged yolk sac, we are still worried, and we will continue scanning this patient up to 12 weeks, that it may result into miscarriage because the yolk sac is bigger. So yolk sac is a good predictor of outcome, provided that the size is appropriate. And here we see the normal yolk sac and the normal fetal pole. If we see a volvulus abdomen in long axis, as you can see in this one, this could be herniation of the bowels, but before 10 weeks or before 11 weeks, this could be the normal phenomena. So people, most of it report it as an omphalocele at that stage, which should be avoided because this is a normal change. ये आपका slow कर. Anyway, there you can see a large yolk sac, and that was resulting into miscarriage. We talked about the size of the yolk sac, that if it exceeds 0.6. Now we are talking of acugenicity of the brightness of the yolk sac. The yolk sac may be filled with, yolk sac, oops, I'm sorry, I'm hitting the end forward and it's going, okay, one more, yeah, no, go back. Okay, there you see the yolk sac. Yolk sac is filled with bright echoes. This is hemorrhage within the yolk sac. And this may also result into miscarriage if seen in early pregnancy. We are all aware of vanishing twins, that it starts with twins and one of them disappears, called vanishing twins. It is important that we should see the twins till the heartbeat is seen in both the feti. If you see two sac and say twins, you might end up in one single pregnancy because one of them got absorbed, and that is quite common. So it is important that one should go for the crown rump length and the heartbeat, and then you are sure that this is a normal pregnancy. Adnexal masses, which can be very confusing sometimes. This is pregnant patient and we see a very large mass. This is not corpus luteum. This is a degenerative fibroid attached to the uterine wall, which was mistakenly reported as a large corpus luteum cyst. So degenerative fibroids, they look absolutely cystic, and we are so satisfied that yes, corpus luteum is there. The corpus luteum was absent in that case. And you can have ovarian cyst with hemorrhage, with pregnancy, that is also going to be followed up at a later stage. This is a patient where you're seeing the pregnancy within right here, but you see a cystic mass all around. We scanned further. We saw this. And when we scanned further, we saw that the fluid was around that was increasing, and then, oh wow, that was an abscess surrounding the pregnancy. And that is why we are not very good friends with Dr. Nadeem, because I would put needle, and when I put the needle in this one, it turned out to be an abscess. That is the way to do it, and I'm writing that it is abscess on the top. So this was all abscess surrounding the fetus. The only method, the management, would be to put the needle diagnostic and turn into therapeutic and aspirate completely. If you see so big heads, calcified fibroid can mimic like a head. These are not two heads on side. There are twins right here. There is a pregnancy sac and the fetal pole, and these are all calcified fibroids, which was reported as 30 weeks pregnant lady, and she says, I can never be 30 weeks because I missed my period on that day. So let's talk about very quickly some of the images. Thin discontinuous ring, angular sac, and subchorionic lucencies makes the diagnosis of abnormal growth. When we talk of abnormal sac, the growth 0.25 to 11, empty sac at 2.5, that means 7.2 weeks, and if we don't see the fetal pole by that time, we are labeling it as a blighted ovum. So you have to wait till 7.2 weeks. I cannot make a blighted ovum at 6 weeks. An abnormal yolk sac position, which we have already discussed. This is a very famous drawing by Frank Netter, and trying to tell you that there is a lot of overlapping in miscarriage. All the 4 images are different. They look alike on ultrasound, and we can miss the diagnosis. We can say incomplete abortion, we can say missed abortion, we can say incomplete abortion. The terminologies will change because of this region. If the sac is irregular, we are sure that this is a more than 8 weeks pregnant, but the sac is irregular, so it's a miscarriage. This is a linear cystic space within the uterine cavity. I don't know whether she is just pregnant, should I wait, or should I say this is miscarriage? Both are dangerous. So what we do is we tell the patient to wait for a week or 10 days and repeat the ultrasound, so that we are very careful. The blighted ovum will be well defined. This is the patient where I reported blighted ovum. The gynecologist sent me back this patient after 10 days. Musarrat, I think the sac is growing. Would you like to review? And when I reviewed, it was still blighted ovum. In blighted ovum, the sac tends to grow. So PV examination will tell you that there is a enlargement. And this is a classical picture of our blighted ovum. Angulation. If you see an angulated sac, it's a miscarriage, provided we don't see the fetal pole. If the fetal pole is there, then this will not be reported miscarriage. So you have to see when there is no fetal pole and the sac is angulated and has crossed 7.2, then we are going to say it is resulting into miscarriage. Showing you that there is a fetus and we are seeing the angulated, but the heartbeat is there. This is 3 findings in one patient. You can see a bright dot in the center right here. This is a collapsed yolk sac. sign of miscarriage. We see fluid collection adjacent to the sac, subchorionic bleed. And the third one is that it is angulated. So 3 findings in the same gives us confidence that this is a miscarriage. Now there is a confusing situation. Is it twins or it is a septa and the patient is bleeding? So maybe it was twin, one missed abortion, other is continuing. So here we can see this is the bleed, or it could be that second sac which is absorbing, and the number one, the fetal pole in the other one is growing very well. So in this situation, after 3-4 weeks, we might not see this cystic space. Dr. Musarrat, आपने पहले तो कहा था ट्विंस हैं, बाद में आपने इसको सिंगल कर दिया, गड़बड़ क्या है? This is a common problem which we come across. This is the patient where we see the sac and we see this bleed. The first question to the patient, are you bleeding? And she says no. मैंने कहा कि फिर तो ये concealed hemorrhage है. तो मैंने पेशेंट को कहा कि ये तो अंदर कुछ खून जमा हुआ है. वो गई, नेक्स्ट डे उसको ब्लीडिंग हो गई. जाके गायनेकोलॉजिस्ट से कहा कि जो डॉक्टर मुसर्रत ने अल्ट्रासाउंड किया ना, उसकी वजह से मुझे ब्लीडिंग हुई है. मैं तो बिल्कुल ठीक थी. अगर वो ये नहीं कहते कि ब्लीडिंग हुई है तो मुझे ब्लीडिंग नहीं होती. दिस इज व्हाट वी कॉल एज concealed hemorrhage. मुझे किस तरफ करना है? I'm trying to go forward. Normally one should have computer with you so that you can play fast because that wastes your time. But anyway, there you can see a sac. हाँ ये मैं कर रहा हूँ मगर वो. And with this you see another cystic space. This is double decidual sac sign which can grow to a large size. Very interesting. This was a doctor who was pregnant. तो मैंने उसको कहा, मैंने कहा कि I don't charge doctors, so why don't you come again after a week? पहले मैंने रिपोर्ट किया कि ये 7 weeks है, fetal pole नज़र नहीं आ रहा. After 1 week I said, oh yeah, congratulations, fetal pole आ गया, you are 6 weeks. कहने डॉक्टर मुसर्रत आपने पहले कुछ कहा था, आप कुछ कह रहे हैं. एंड देन आई कॉल्ड हर अगेन आफ्टर अ वीक. मैंने कहा तुमसे कौन से मैं पैसे चार्ज कर रहा हूँ. सो आई कॉल्ड हर थर्ड टाइम. सो दिस वाज एक्चुअली फर्स्ट रिपोर्टेड एज अ प्रेगनेंसी सैक विच वाज नॉट द प्रेगनेंसी सैक. सो द एक्चुअल प्रेगनेंसी सैक वाज दिस वन विच वाज स्मॉलर ऑन द लेफ्ट साइड, एंड देन शी डिलीवर्ड अ नॉर्मल बेबी. These things are very tricky, especially when you're dealing with doctors. मैं जब मेडिकल फील्ड में आया, one day I met, कुछ ही दिन हुए थे अल्ट्रासाउंड स्टार्ट किए हुए, I met डॉक्टर फरीदू सेटना, and he gave me a piece of advice. मुसर्रत, can I give you advice? मैंने कहा yes. कभी भी डॉक्टर से और रिश्तेदारों से शॉर्टकट नहीं करना. दे आर द मोस्ट डेंजरस पेशेंट्स. अगर दोबारा बुलाना है दोबारा बुलाओ, 3 मरतबा बुलाना है 3 मरतबा बुलाओ, लाइक ए नॉर्मल पेशेंट. नो शॉर्टकट्स. दिस इज वेरी इंपॉर्टेंट मैसेज. एंड दिस इज ट्विंस. दिस इज द ब्लीड. नाउ इफ द हार्ट बीट इज देयर एंड यू सी द ब्लीड इन द adnexa, you do the circumference of the sac, you do the circumference of the bleed. If the bleed is less than half the size of the sac, this pregnancy will continue. If the bleed is 50-50, this may result into miscarriage. And of course everybody knows that we are dealing with molar pregnancy, so thecal luteal cyst on both sides. I'll skip this. When we talk of miscarriage, chromosomal abnormalities come into play. I'll touch on that point, then we'll go to cervix. there are few certain things to look for. If you see a cyst in the wall where the placenta is thought to be implanted, that is an underlying chromosomal abnormality unless proven otherwise. And this was a patient which we followed, resulted into anencephaly at 12-13 weeks of pregnancy. We couldn't pick up anything before that except that this cyst, and I recorded this cyst, that there is a cyst, as you can see right here. So be careful. I'm sorry, I'm trying to, okay. Body wall defect with cystic space, which we call as megacystis, is a chromosomal abnormality. And those chromosomal abnormalities, if you find one subtle sign, is the patient where you need to follow it up more closely. And there you can see the same picture. Talking about the nuchal translucency, I've come across many patients at 10 weeks, normally recommended 11 weeks, 3 days. But if you see nuchal translucency by 10 weeks, it is a sign of a chromosomal abnormality. We don't know which one. Most commonly, which we have come across at 10 weeks, is Edwards syndrome. So anything which crosses 3 figure, you are worried about it. And at 10 weeks is not the time to really routinely do it. But if by chance the patient comes at 10 weeks and you saw this, I call it as a knee-elbow sign. That means I'm scanning from the back. This is a chromosomal abnormality. Sorry about, this is another one where we see the nuchal translucency. I beg to disagree with Kypros Nicolaides on this. He recommends front view. I always enjoy the back view because that gives me more accurate. I'll not go into the debate of that, but I beg to disagree with Kypros Nicolaides. And this is again megacystis, sign of underlying chromosomal abnormality, and that may result into miscarriage by 14 weeks. Okay, I'm sorry, this is taking my time. If you see septations in nuchal translucency, it is cystic hygroma. In first trimester cystic hygroma, don't go for further testing. This is definitely abnormal. Abort the baby. Don't wait. Okay. Now this screen is not working, so I have to go back again. This screen is not working for me. So there you see the thin septations. And there you see the nuchal translucency. Okay, it comes and goes. अब आ गई, but anyway, कभी-कभार ये गायब हो जाती है तो anyway, it's working now. There you can see the nuchal translucency. That is a sign of okay, ये hit नहीं कर रहा, I don't know, क्या है तो इसका cell weak है या इन्होंने कहा है कि मैं मैनुअली कर देता हूँ. नेक्स्ट स्लाइड प्लीज. दिस रिमाइंड्स मी कि जब मैंने पहला पेपर शेरेटन में पढ़ा तो डायस के ऊपर मैडम जुबैदा अजीज़ थी, मैडम रज़िया अंसारी थी, मैडम महमूदा सईद थी, और चेयर was holding by Stuart Campbell. Stuart Campbell बहुत सारे लोग नहीं जानते. He was the gynecologist, obstetrician of Lady Diana, by the way. और मेरा पेपर था आर्टिफैक्ट और अल्ट्रासाउंड. तो मैंने कहा कि नेक्स्ट स्लाइड. जब मैं ऑडियंस में जाके बैठा तो मैंने अपने एक प्रोफेसर मेरे बराबर में बैठे थे, मैंने उनसे पूछा कि मेरा कैसा लेक्चर था. कहने हमें तो सिर्फ ये समझ में आया, नेक्स्ट स्लाइड प्लीज. Anyway, so this is again an abnormal baby. Next slide, please. And this is the typical picture which Kypros Nicolaides talks about, that you see a long axis and you see differentiate from the amnion and the other structures. Next. And this is what I do. I also see from the back, which gives me a more accurate picture. Next slide. Corpus luteum I've already talked about. The patient has got uterus, which is empty, and I see the corpus luteum. मैंने जब 2 years of PGship की गानी में डॉक्टर महमूदा सईद के साथ वे बैक, तो उस ज़माने में ये था कि जब वो एक मिसकैरेज होगा, दूसरा मिसकैरेज होगा, तीसरे मिसकैरेज के बाद सोचेंगे कि क्या करना है. अब जो है वो कॉर्पस ल्यूटियम देख लें कि कॉर्पस ल्यूटियम है या नहीं है. नेक्स्ट स्लाइड. Sometime you see the pregnancy in the cervix. I'll skip this slide and talk about the cervix now. Next slide again. Next slide. This was an abscess. Now we talk of os completely open. मैंने 5 पेशेंट्स अपनी क्लिनिक पे डिलीवर किए हैं. अ न्यूज़ फॉर एवरीबडी, क्योंकि मेरे कुछ एक्सपीरियंस था गायनी ऑप्स का जिना से. पेशेंट वॉज फुल्ली डायलेटेड और शोर करती हुई उसको और फ्लोर पे लिटा के और डिलीवर्ड द बेबी. पेशेंट कहने लगी, डॉक्टर साहब कितने पैसे हुए? मैंने कहा जाओ भाग जाओ. सो दिस इज व्हाट कैन हैपन इफ यू सी द ऑस इज कंप्लीटली ओपन. नेक्स्ट स्लाइड. So let's talk about very quickly in 5 minutes because I'm given less time. Next slide. Preterm labor, everybody knows, so I'll skip this slide. It contributes to this problem either singly or in combination of the cervix length. Next slide. Timely recognition is very important so that you can manage, and Dr. Nadeem is going to talk about management. It plays a very important role. Ultrasound. Next. The changes the cervix undergoes are essentially the same in term labor, preterm labor, and cervical incompetence. That is why ultrasound is important. Next slide. In each of this, it starts internally. तो अगर गायनेकोलॉजिस्ट पीवी एग्जामिनेशन करेंगी तो वो उनको बाहर से एक्सटर्नल ऑस वेरी वेल के बंद है, खुला है, but not internal os. You can make an idea, but ultrasound gives you a better picture. Next. Early finding of V or U is what we call it invagination. Next slide. So here is a picture, and we can see the cervical length. One of the professor in United States, उसने एक sabbatical किया 1 साल का, और उस sabbatical में ये किया कि he was studying the cervix. So 6 months he was in Canada and 6 months he was in Japan. उसका ये ख्याल था कि जापान की लड़कियां छोटी हैं तो उनका सर्विक्स छोटा होगा और कैनेडियन लड़कियां लंबी हैं उनका सर्विक्स बड़ा होगा. And when he did the research he found the opposite. So there is no hard and fast rule. Next slide. And if you see the echogenic, now I don't have the control you can see the spindle-shaped echogenic area in the cervix, which is the mucus plug, which defines that the cervical length, true length, will be what, from what end to what end. Next slide. We overcall previa, whereas अगर कोई लेक्चर ले ले प्लेसेंटा का तो नेक्स्ट डे से सबके प्रीविया शुरू हो जाएंगे, क्योंकि लेक्चर दिया था डॉक्टर मुसर्रत ने. उन्होंने कहा ओहो बस अब तो. सो इट इज ओवर कॉल्ड. नेक्स्ट स्लाइड. वी इवैल्यूएट सर्विक्स बाय 3 methods: ट्रांस एब्डोमिनल, ट्रांस लेबियल एंड ट्रांस वेजाइनल. नेक्स्ट. दीज आर द pitfalls: over distended bladder, lower uterine segment, post void, and critical angle artifact. And I'm going to explain one by one very quickly. This cervix looks 5 centimeter absolutely normal. This is not the true cervix because this is over distended bladder, which makes elongated cervix and the wrong diagnosis. Next slide please. And we can see, we cannot even see the cervix when there is segmental contraction. So segmental contraction pe I got the role of honor for presenting in 1988 in World Congress in Washington DC. I cannot see the cervix because post-void segmental contractions are generated and we cannot see the cervix. So wait till the segmental contractions are gone. And here we see segmental contractions looking like placenta. In reality, that measurement which I'm showing is the cervix. Next slide, please. And this is what is called as critical angle artifact. Because of the curvature of the uterus, it makes a triangular area right here. I wish I had my laptop. I have my laptop, but they said you cannot connect it. So there you can see critical angle artifacts makes the cervix smaller. Looks smaller. It is not smaller. This is what you have to learn in physics. Next slide. If I tell you that this is a scan of the same patient, same time, left and right. Right one shows BPD. The left one shows normal uterus endometrial lining, absolutely no sac. She was pregnant, 30 weeks. Lower uterine segment can mimic the picture of a normal uterus, and you miss the entire pregnancy, which is 30 weeks pregnant. Next slide. Transabdominal, bladder too full, bladder too empty, cervix will be obscured. Next slide. If you over-distend the bladder, there is a problem. If you empty the bladder, there is a problem. That is why endovaginal takes a role in playing it. But before we go for transvaginal, we do transperineal. And transperineal gives you better images sometime. Next slide. And this is how we use the probe. We put the plastic, in fact the gloves and the gel, and we do the labial scan. Next slide, please. This is the way the pictures look like in translabial. Next slide. And that's how we turn the image to see that image. One has to learn that. Next slide. And this is how the cervix would look like. So sometime I don't have to put the endovaginal probe. Even the labial scan will give you the diagnosis. And this is the os completely open on labial scan. Next slide. And this is previa. Placenta is previa, and you can see that bright white line. I wish I had the pointer very sharp so I could have explained, but I have to go fast. And endovaginal scan is the best for cervix. Now it is recommended, if previous miscarriage, do endovaginal for cervix at 14 weeks. If not, no problem. Then at 20 weeks, one should do the endovaginal for cervical length establishment. This is what is recommended. Next slide. And that's how you do the endovaginal. Next slide. And this is the endovaginal scan, which is showing normal cervix. This cervix looks absolutely normal. But when we do put pressure on the abdomen, next slide. Next slide. Look at this picture, normal cervix, next slide. And the os appears to be beaking. Next slide. Os appears to be funneling. This is the same patient. Next slide. And the os is completely open. All the membranes are bulging out. This is the beauty of, which was discovered by Professor Guzman. We call it compression. There is a method. I'll not go into the method. I will not finish that. Next slide, please. And this is a short cervix on endovaginal. Very short cervix. Next slide. This is the normal cervix on endovaginal. Next slide. Now, can we know the size of the cervix when she is not pregnant? Only when there is a fluid collection, not the echogenic line, because there is no mucus plug at that time. Next slide. And that's a normal cervix length. Next slide, please. Endovaginal is very good, but when you push the probe inside, cervix agar khula tha, to band bhi ho jayega. This is a trick. I'm not going to go into that. By the way, do you know that how much you have to push the endovaginal probe inside? क्योंकि प्रेशर का तो पता नहीं होता, आपने डाल दिया अंदर. सर्विक्स ओपन था, आपने प्रोब दबाया और सर्विक्स को क्लोज कर दिया, गलत डायग्नोसिस हो गई. तो हाउ डू यू नो कि इतना प्रेशर नहीं डालना है? Anybody knows what is the size of the vagina of that lady where you are examining? There's a trick. Tell the patient to fold the fingers like this, get hold of her right finger, the middle finger, from the knuckle to this, from knuckle to this is the size of the vagina of that patient. And then you know what you do the probe. Suppose this is the vagina, so you go 1.5 centimeters up, and when you put the probe inside, your thumb is the barrier. It will never collapse the cervix. Next slide, please. How much is vagina? How much is cervix? We don't see vagina when you do endovaginal, but you do see cervix, and you do see the measurement. This is the normal. There is so much to talk on every slide, but I'll skip because of the time. Next slide, please. So the normal residual is 2.6 centimeters. This is in your book, so I will not waste my time. This is the relative risk factor. What should it be at what time? Next slide. 2.6 to 5 is a normal range because we are talking of 50th percentile, 25th percentile, or 10th percentile. The 10th percentile comes to 2.6. Next slide, please. Obviously, trust your vaginal ultrasound. That is what is TYVU. Next slide, please. And this is what we call it as cervical stress test done by putting the pressure on the abdomen. Next slide. And this is the cervix. Next slide. I'll skip because next slide. This is incompetent cervix. You can see that fluid. Next slide. And that's the cervix normal. Next slide. Normal cervix endovaginal. Next slide. There are stories on each and every, but I'll skip because I've overshooted my time. Next slide, please. This is what I believe in. For last 41 years I've been teaching. Give to the world the best you have, and the best will come back to you. Next slide. Attention is the rarest and purest form of generosity. Next slide. Thank you for being generous.